Awesome. Thank you so much, Sean, for that really kind introduction. I'm going to go ahead and share my screen. So it's been awesome working with Sean and the rest of the Prevention of Blindness Society here in the metropolitan area through the Emerging Leaders Group and also just the organization in general. I'm really kind of connecting to the community and getting opportunities like this to educate you. Today I'm talking about cataracts, as he said. Cataracts as a comprehensive ophthalmologist is kind of like my bread and butter. Just today, I started my day in the operating room doing cataract surgery. Earlier today, I talked to some residents about cataracts in a lecture, and now I have the chance to talk to you in this afternoon opportunity. So I'm going to be talking about cataracts, and I want to just dive right in to my presentation. So just sort of an overview of what we're going to talk about today. I'm going to talk about what cataracts are, what causes them, what are symptoms of cataracts, how we as ophthalmologists detect them, how we treat them, and then what you can do sort of in your day-to-day activities to prevent the progression of cataracts and to protect your overall vision. And I'm hoping that as we go along, some of you will have questions and we can make this interactive towards the end because I really want to hear what things that you want to know about cataracts as well. So what is a cataract? So this is a cross section of the eye. So if you imagine this is the front of the eye, this is the part of the eye that you see when you are looking at someone. The most superficial part of the eye is the cornea. So that's a clear window through which light passes. Towards the front of the eye, just behind the iris, which is the part of the eye that we associate it with color of the eye, like brown eyes, blue eyes, that's the iris. But right behind the iris is the lens of the eye. The lens of the eye is the part of the eye that focuses light rays. So as you see an image in front of you, light comes off of that, passes through the cornea, passes through the lens, and the lens, because of its shape, focuses those light rays to the back of the eye or the retina. So the retina is this membrane all across the back of the eye that transmits the light message back through the optic nerve to the brain so that we perceive images. So the lens is the part of the eye that we're going to focus on today. That is the part of the eye that eventually develops into a cataract. So a cataract is a clouding of the eye's natural lens. So we just saw in the previous photo kind of where that lens is relative to the rest of the eye. When we're born, typically the lens is clear. So the proteins are arranged in a compact way that light can pass through this clearly. Over time, the protein composition of the lens changes. So the lens is made of things called crystallins. These are special proteins that have a special composition and orientation. And as we age, the lens changes from this clear lens into this cloudy lens. It can develop a cloudy color that often will be white or brownish in appearance. For the purpose of today, I'm mainly talking about the most common types of cataract, which are age-related cataracts that everyone gets if they live to be long enough. There are other types of cataracts, including congenital cataracts, that affect individuals at birth or in infancy. In those individuals, they are not born with a clear lens, and it's sort of a different pathology than what we'll talk about today. But in most cases, we're born with a clear lens, and over time, it develops into a cloudy lens. And we'll talk a little bit about kind of why these changes happen as we go through the presentation today. So what causes these changes? Typically, the biggest thing is aging. So unfortunately, we haven't yet figured out how to stop that process entirely. Everyone gets older over time, and it's this aging process of the lens that typically begins to manifest around age 40. So once we get into our 40s, we start to see early changes in these lens composition. Again, these are proteins that are changing kind of how they're oriented and their water solubility so that they go from being nice and clear and neatly organized to being a little bit more disorganized and having this cloudiness. There's also a process within our body called oxidation, and this is happening all over our bodies and all the cells of our body, including the cells of our lens or the eye. So this is going to come back later because we're going to talk about things that slow down the oxidation process or antioxidants, because that is part of this process that causes these cataracts to develop. In addition to just kind of the aging process that's happening on the cellular level, there are certain situations where cataracts can develop more quickly. This includes in individuals that have a strong family history. So I mentioned already that everyone gets cataracts if you live long enough. So just because you have a parent or a grandparent that has cataracts doesn't mean that's necessarily a strong family history. But if you have a history of people in your family getting cataracts early or really severe, that is definitely something that we consider. Certain medical problems can also cause you to develop cataracts earlier than we might expect or cause them to progress a little bit more rapidly than we would expect. One of the biggest ones in this category is diabetes. So diabetes can cause cataracts that appear often whitish in appearance, and can affect different parts of the lens because of how the sugar is stored inside the lens. And then we often see these develop a little bit earlier than we would expect with a typical age-related cataract. Also can be seen if you have a history of any injury to the eye. So trauma is a big reason why the proteins in the eye get sort of shaken up, and can precipitate cataract development. If you've had a history of eye surgery, that can also lead to development of cataract, especially a history of surgery on the back of the eye or the retina. When patients proceed with surgery to the retina, they're often counseled that this may happen as a result of that surgery, just early cataract formation. But luckily, as even Sean mentioned at the start, even though this happens and this develops, it is treatable. So we're going to talk about the treatment towards the end. Radiation treatments also can cause certain types of cataract. And this is mainly radiations that is near the eye. So radiation effects have a degree of proximity. So if you are getting radiation on your toe, it probably won't cause a cataract to develop. But if you are getting radiation on your thyroid, like in your neck region, or anywhere near the eye, there is a higher chance that that can contribute to development of a cataract. Another big one is sunlight exposure. So the ultraviolet or UV light rays that we get outside contribute to these changes in the lens. And this is cumulative. So every time you walk from your house to your car or your car to the doctor's office, that little bit of light exposure outside over many years can add up. And we'll talk about some ways to kind of address this and what you can do towards the end. And then certain medications, this includes corticosteroid medications, can also cause cataracts to develop earlier. And we use corticosteroids in medicine for a lot of different things, including allergies. So sometimes there can be nasal sprays, eczema, and other skin findings we can treat with creams. So different routes that we prescribe corticosteroids for a lot of different reasons, but those use can lead to cataracts developing again a little bit faster than we would expect. And then lastly, smoking. So smoking, as you can imagine, ages the whole body, including the eyes. So smoking and the amount that you smoke can also age the eyes and cause cataracts to develop quickly. So in general, cataracts develop slowly over many years. When you have any of these things in particular, eye injury or trauma, diabetes that's not well controlled, or certain medication, what we see often is that those cataracts develop very quickly over a short period of time. In terms of the symptoms of cataracts, so as this cataract is growing, and again, often this is happening slowly over many months to even many years, what are the symptoms that you are going to be experiencing? So if you imagine that this picture here is the normal standard picture and what we would expect you to see without a cataract, one of the things that can happen is that cataracts can make images appear dull or yellow. So this is obviously very sepia toned, but if you imagine, as that cataract goes from clear to brown, like I showed you in the beginning, the images are going to have that same kind of tint. So going from something that has a lot of different colors to the color sort of appearing washed out, or maybe even a yellow or orange tint and just looking overall dull. Another symptom is just images appearing blurry. So as the cataract grows, those proteins become more and more dense, and the light that passes through the cataract is less and less. So as less of that light passes through, less of the image of what your eye perceives is getting to the retina and eventually to the brain. So things just look blurry, or certain spots can even be sort of missing in terms of what you're seeing. It can also cause distortion or ghost images. This depends on sort of the part of the lens that these changes are occurring, if they're occurring in one part more than the other. And then a last big symptom that we often hear about is glare. So this is especially noticeable when you're driving at nighttime or in the rain. So when you see oncoming headlights, those should look like crisp lights with nice crisp borders. If those lights look like starburst or have sort of this linear glare to them, that could be a sign of cataracts developing as well. So as you can see, there are a lot of different ways that these can present, and sometimes you'll have multiple symptoms, or sometimes you may only have one, and they can affect you to varying degrees depending on how big the cataract is, and also what your day-to-day activities are, and the things that you do um, in a given day. So in terms of symptoms, I wanted to show you these paintings from Monet. He is historically known to have cataracts, famously. This is a footbridge that he drew in 1899. So at this age, he was 59. So I mentioned typically we start to develop early cataracts, 40s, 50s. So that this age, this is what he's seeing without any cataract present. This is him at age 81 in 1921, the same footbridge. So you can see that the same footbridge, some of the features, the details have lost their clarity, things are blurred together. And the other big thing I hope you can appreciate is that the color changes from green and blue to this more brown and orange appearance. And that is, again, because of that brunescence or browning of the lens as it changes over time. It's noted in history that he actually had surgery done when he was 82, so a year after this. And most patients, if you talk to anyone who's had cataract surgery, most of them are really happy. They can suddenly see so much better. Monet was upset after he had his cataract surgery because he was used to seeing things in orange and brown, and he said that everything appeared so bright and so blue, and he did not like that as an artist. So this is just one historical example where you can really see over years how that can change in terms of the distortion, the blur, and even that yellow brownish appearance. How is a cataract detected? So as these cataracts are growing over time, the best way for us to detect them and treat them is for you to come in so that we can perform a couple different assessments to diagnose a cataract. The three main things that we do in our exam in terms of looking at cataract is one, refraction and visual acuity. So this involves checking what you see on that chart, where you have to read the letters to us and we grade that. As you know, you probably heard of 20/20. 20/20 is what we consider perfect vision. So we give your vision a grade on that chart based on what you can see at a defined distance. And then we also use this instrument, which is called a phoropter, to see if we can correct your vision to see the goal again is 20/20. So we both check your vision without glasses and then also see how well you can see with some help with some lenses in front of the eye. Again, going back and thinking about that picture at the very beginning, lenses go in front of the eye. So if the lens inside of the eye is clear, we can give you glasses in front of the eye to help you see better. If the lens inside of the eye has a cataract and has become cloudy, even if we put glasses in front of the eye, things are still going to be a little blurry as the light passes through. A second thing we will do when we evaluate you is called a slit lamp examination. So this involves sitting a little contraption that has a place for you to rest your chin and your forehead. And then we have a special light and magnifier that allows us to have a binocular view of the eye. This is really useful to look at the front of the eye, as well as view the lens. And with special lenses, we can also take a look at the back of the eye. And then lastly, we do what's called a dilated retinal exam. So dilation involves giving some drops to the eye to open up that tiny pupil space, so that we can look at how well your pupil opens up. We can get a better view of the cataract because that's directly behind that pupil. And then we can also look at the retina because as we assess why you might have a decrease in your vision, we want to try and figure out, is it because of the cataract? Is it because of something else? Some of those other disease processes Sean mentioned, like macular degeneration or glaucoma. So the dilated exam helps us sort of tease out where exactly the decreased vision is coming from. So these are all things that we do in our office to just get a better idea of how the cataract is affecting you and what the exam is. In terms of what we see on the exam, in a patient with cataract, we open up the pupil with dilation. So this pupil is mid-dilated, so this is a little bit larger than it would be at rest without dilation. And then you can see this space in the middle. Normally, we like that space to be black. So if you look at someone and you see their pupil, usually that space is black. That's a clear opening to basically this cavity of the eye, and that's why it appears black. In patients that develop really big cataracts, you can see that the middle appears white or sometimes even brown. You may see someone and they can say that they have decreased vision. It doesn't look as dramatic as this. So this is a pretty advanced cataract. You can develop cataracts and it might not be noticeable to anyone looking at you face on. So just because you don't see a cataract in someone else or in the mirror doesn't mean that they don't have a cataract. This is just one sort of more dramatic example of what we could see when we look at you during our examination. So once we detect a cataract, we can talk about treatments. When cataracts become what we call visually significant, then we can definitively treat them with surgery. In terms of what qualifies as visually significant, that's a conversation that you have to have with your ophthalmologist. So I mentioned one of the things that we check is your vision on the chart. So a cataract could be visually significant if you get to a certain level on the chart and can't see any better. For example, we often use 20/40 as a reference. Um, but some people see 20/40 and they're very happy with that. So if you're functioning well at certain vision on the chart, it doesn't mean automatically that you need to have surgery. Again, we have a conversation about how it's impacting your day-to-day activities. Visually significant can also mean, separate from what you see on the chart, how your functional vision is impacting your day-to-day activities. So I showed you earlier that often one of the signs of cataract is glare with oncoming traffic at nighttime. This one it can be big, and patients often will have good vision on the chart. So they may have even 20/20 vision. But if you tell me that you are seeing 20/20, but you have really debilitating glare with traffic when you're driving at nighttime, and I examine you and see a cataract, that could be a reason to take you to surgery, even if your vision on the chart might not be so bad. So it's really this conversation about how the cataract is developing in terms of what we see on the exam and how that's affecting your functional vision, both in terms of what you see on the chart, as well as sort of your day-to-day activities, your ability to carry out those activities as independently as possible and safely as possible. And then another reason why we sometimes do cataract surgery is because just like the cataract is blocking the light in, sometimes the cataract can also block our view in to see the back of the eye. So in patients that have really big cataracts, if we're trying to follow them for a known history of, for example, retinal detachment, macular degeneration, or glaucoma, if you can't see out of that eye because of that cataract, we can't see back to properly manage some of those other disease processes and treat them if we need. So another reason that we sometimes do cataract surgery is if, even if the patient doesn't have a lot of complaints about the vision, if it's impacting our ability to manage other things, that's another reason that we might take it out. In terms of what happens once we determine that those cataracts are visually significant, the definitive treatment is surgery. So we do surgery for cataracts. It's the most common outpatient surgery procedure in the United States. Sean mentioned earlier that this is the leading cause of blindness in the world, but luckily we have a curative surgical treatment that's been around for many years, and we have this available across the United States and in DC in particular. We definitely have access to surgery so that we can treat this. So in terms of what surgery entails, so as a surgeon, we make a tiny opening, and through that, we insert a probe, an ultrasonic probe, that essentially kind of breaks up that cataract, that dense cataract that has developed, and suctions it out. There's a little capsule that basically contains this cataract. And the reason we are able to access this cataract is by making a small opening in this capsule towards the front of the eye. This can be done with a sharp tool or a laser. There are a couple different techniques available, but no matter what technique is used to open that and start the process of breaking down the cataract, all cataract surgery um, will involve this step of removing the lens. And in the United States, we use this ultrasonic probe. In other parts of the world where they don't have access to this, it's actually possible to use just some instruments to remove it without breaking it into smaller pieces. But this is the most common way that we do it here. After we take that cataract out, we can't leave that space empty because I mentioned in the beginning that lens that's there is what focuses light as it comes in and passes through and goes to the retina. So if we left this empty, there would be nothing to focus light on the retina. So instead, we put a clear synthetic lens in its place. This lens is made of an acrylic, so it's a plastic lens that stays in your eye forever. It stays within this natural support system of the eye called the lens capsule, and that stays inside your eye and helps you see more clearly after surgery. So very straightforward process for us, but I know it can be scary to go through surgery, including eye surgery. So I'm sure there will be some questions about that at the end, and we can talk about that. But essentially, using energy and ultrasound to remove the cataract that has developed, and then replacing it with a nice clear synthetic lens that stays in your eye forever. There are different types of lenses that we can place inside the eye depending on your needs. I'm not going to talk about those too much today, but there is technology available that can help you see either far away really well and use glasses for reading, or sometimes we can even put essentially like a bifocal or multifocal inside of the eye to help you be a little bit more independent from glasses. And that technology is constantly evolving in terms of how we're improving the implants that we put inside the eyes. In terms of cataract treatment, I just wanted to walk you through some expectations. If any of you have cataract surgery coming up or on the horizon in the future, so we can remove some of the anxiety around it. But what to expect during your surgery. So I kind of walked through what we are doing in terms of steps, but I wanted to also walk through kind of what your experience would be as a patient. So this is just a sample photo of what you might see in the operating room during cataract surgery. As a patient, you will lay flat across a bed. There's a surgeon who performs the surgery, and then there's someone from the anesthesia team as well that helps administer some anesthesia. Typically, for these surgeries, we do what's called monitored anesthesia. So you'll have an IV. You may be familiar with those for receiving fluids, but through that IV, there's some medicine given to keep you calm, comfortable, pain-free. We also give some medicine to the eye, so that again, you're comfortable throughout the entire procedure. And then as we proceed through surgery, you're covered with something to keep everything nice and clean. So this is an in and out procedure, meaning you come and go home the same day. Whether you have this done in a hospital or a surgery center, that's the typical pattern that we see. And then most people are back to their usual activities within a couple days. So in terms of what to expect during your recovery period, you may go home with a little plastic shield or an eye patch. That's totally normal. That's because as we make those little openings to remove the cataract, we usually don't even put any sutures. So this kind of seals up on itself within the first week or so. That little cover helps to remind you not to rub the eye, not to stir things up too much. After surgery, you are usually on some eye drops. These include a anti-inflammatory eye drop to help with the healing process, also to help with any pain or discomfort or light sensitivity, because most of the discomfort that you experience after comes from inflammation, which is expected after surgery. This is typically not a painful surgery and not a painful recovery. We often don't even have to prescribe any sort of pain medications for our patients because they do so well. And another medicine that you'll get in drop form usually is going to be an antibiotic, and that you'll take just for a few days, and that helps to decrease your risk of infection following surgery. And your surgeon will see you at certain intervals after surgery to see how you're healing up. And then once you're completely healed up, we check your vision to see if you need any glasses, and then we help you get those glasses so you can see well again if you need them. In terms of what you can do to protect your vision, once you reach a certain age or once you hear that you have cataracts, or even before that, if you want to just protect your eyes because you know that cataracts are inevitable and will come eventually if you live long enough. Every 2 years, you should go in for a routine eye exam with dilation. Once you are in your 60s, and definitely once you're 65 or older, then you should increase that to at least once a year. If you have other either eye diagnoses or other medical issues such as diabetes or high blood pressure, then we really recommend that evaluation every year. When you're outside, the biggest thing that you can do is to protect your eyes from UV light. Because I said earlier, again, this is cumulative, so every little bit kind of adds up over time. So you want to wear your sunglasses, your wide brim hats, anything to protect your eyes from that UV light exposure, because there will inevitably be some, but you want to kind of protect them so that overall that total is less. If you smoke, quit or cut back at least. Again, smoking causes the whole body to age, including the eye. And in the eye, cataracts are part of the aging process. So the cataracts that we talked about again today, these are age-related. So smoking is a big factor that kind of accelerates their development. Also, make sure you eat a colorful, varied diet. So I mentioned towards the beginning that the process of this lens changing from clear to cloudy involves something called oxidation. So that's how these cells are changing and aging on the cellular level. If you eat antioxidants in your diet, we can sort of equip the cells to be healthier and prevent and slow down that process. So things in nature that are usually really colorful are nature's way of saying this has a lot of antioxidants and has good vitamins. So this can include things like citrus, like oranges, tomatoes. This can include lots of berries, and then just like green leafy vegetables, if you don't have any contraindications, and other naturally colorful fruits and vegetables are often just a good way of knowing that those probably have a lot of antioxidants. If you develop cataracts but aren't quite ready for cataract surgery, one thing that you can do to get by is just use brighter lights or a magnifier for reading and other activities. This will help you sort of function when you're in that stage where you might have some early signs of cataract, but it's not impacting you enough that you want to proceed with cataract surgery yet. Once you start developing trouble, um, driving at nighttime because of glare or halos or other problems, we do recommend limiting your driving at nighttime because we want you to be safe for yourself and for others. And if it gets to that point, We often do recommend that we treat the cataracts with surgery, but if you're not ready for surgery, but you are experiencing those, we do try and recommend limiting your driving or at least staying in areas that are familiar to you. Um, Take care of your other health problems. So I mentioned earlier that diabetes in particular can cause cataracts to grow and develop a little bit faster than we would expect. But just taking care of your overall health will help protect you from developing cataracts because, again, this is an aging process. And as your body ages, so does the lens in the eye. We recommend getting the right glasses or contact lenses to correct your vision because if your decreased vision is just from what we call a refractive error or needing spectacles or contacts, then you can get by for often many years without needing surgery to correct cataracts, even as they develop. Often glasses and contacts can help you see well for many years. And then if it becomes difficult to complete your regular day-to-day activities, safely and comfortably, that's when we recommend having that conversation and evaluation with your ophthalmologist so that you can consider cataract surgery. That was pretty much all that I had in terms of the discussion because I want to give opportunity to talk to you guys. But if you need additional resources, the American Academy of Ophthalmology has a page called iSmart. They have a lot of different disease processes, and their page on cataracts is very helpful. Prevention of Blindness has their own resource page about diseases and conditions, and cataracts obviously is on there. And then if you need to reach out to me, that's my email, katrina.chinloy@howard.edu. And I'm happy to answer your questions either via email or today as we chat. And I'm happy to evaluate patients. I see patients at Howard University in Washington, D.C., and at Vision MD in Prince George's County as well. Um, that's it from me. I'm going to stop share.
Thank you, Dr. Chin Loy. That was absolutely wonderful and very informative. So for folks for Q&A, you have a couple ways that you can ask your questions. One, there is a Q&A option at the bottom of your screen that you can select. I see some of you have already done that, and we'll get to those questions. Alternatively, if you want to ask in person, you can raise your hand. Now you can do that as one of the options is more. It looks like three little dots. You can tap there, and there's an option for you to raise your hand that way. Before we get into those questions, Dr. Chin Loy, the most common thing we get with people who have cataracts is they are hesitant towards
Mhm.
getting the surgery done. And I'd love to hear from you as a great health educator as well. What sort of things do you normally tell people who are hesitant about the surgery that helps them along the way to make it better decision for themselves?
Right. So at the end of the day, with some rare exceptions, this is an elective surgery. So if someone is hesitant, I think we have to definitely fill in that education gap about what a cataract is, sort of how you can see better after we remove it. But if someone is functioning for the most part, even when I see a cataract, I will let them have kind of time to process that. So at the end of the day, this is an elective surgery. I don't feel like anyone should be pressured to do this sooner than they're ready. One thing that I do recommend is once you hear this diagnosis of cataract surgery, and you know that you have cataracts, I tell people like maybe talk to your friends in your family, your church, wherever your social network is, because as we mentioned earlier, everyone gets cataracts eventually. They just might not be talking about it. So once you start talking to other people, oftentimes I'll have someone that's on the fence and I say, well, now that you know that you have this diagnosis, and I give them information about it, talk to some other people about it. And then they'll come back and they're like, all my friends have had cataract surgery already. So I think it's just something that other people around you may have already experienced and just not talked about. But once they kind of hear from their friends that they had the surgery, that it was okay, that their recovery wasn't as bad as they had kind of thought in their mind, that can put them at ease a little bit.
Awesome. Thank you. Okay, so first question is I'm not there's a technical question. I'm going to get to that one in just a second, but
Yeah.
first I want to ask and it kind of goes along with what I just asked. How long do we want to wait to get surgery if the cataract's not, quote, mature or ripe? How long should
Mhm.
we wait?
Yeah, this is again just a conversation that you have to have with your ophthalmologist, and it's going to be different for everyone. So, I was mentioning in my presentation, like we have this idea of what is visually significant. So on the chart, it can be like a certain level that you're reading 20/40, for example. But more important than that to me is how it's impacting your day-to-day activities, how it's impacting your functioning. If you have 20/40 vision, um, you would qualify to have this covered by your insurance and we can take care of it. But if you tell me that you're hesitant, that you're able to drive, you're comfortable driving, you're able to dress yourself, cook for yourself, do all of these things independently still, you're not someone that I would feel the rush to get that cataract out. But if you tell me that the glare or the other symptoms are really bothersome, then that's someone that I would want to take that cataract out sooner. I mentioned some scenarios also in my presentation where sometimes the cataract is impacting our ability to manage other disease processes like diabetic retinopathy or macular degeneration. So, if you're on the fence about having the cataract out, but I know that if we took the cataract out, we could not only help you see better, but also take care of some of those other processes, that's another situation where I would encourage you to get it sooner than later.
Thank you. And speaking of the surgery and the lenses, how long do these replacement lenses last, and is there potential for migration?
So that lens stays inside the eye for the rest of your life. It's supported by this capsular bag, which is this natural, very, very thin bag that is tied to the eye essentially by these thin hair-like strands. So that's your natural anatomy that stays intact forever. But as you can imagine, if there's a lot of trauma to the eye, so if you get hit in the eye with like a ball or something, it can get dislodged. And that's true of your own natural lens as well, not just the new lenses that we put in. So if you have trauma to the eye, your natural lens and that support system can get shaken up. So they do not migrate unless there is like trauma or some other sort of reason why the support system of the eye is not as healthy. There are certain medical conditions, certain soft tissue diseases like Marfan syndrome or something called pseudoexfoliation, like these connective tissue diseases where your support tissues are not as strong. So there are certain diagnoses that these support systems might not be as strong with, but the main reason if it moves is because of trauma. So otherwise, those lenses stay inside your eye forever. Sometimes the eye, the surface, like the curve of the eye can change, so your prescription might change, but if your prescription changes, typically we don't go back in and kind of exchange those lenses and go through a surgery again. What we usually will do is just change your glasses prescription.
Gotcha. Okay. And is there a type of diet or supplementation that can help prevent cataract development?
I mean, the biggest thing is, again, colorful, varied diet, antioxidants high in your diet. I know in that question they mentioned ARIDS and AMD, so there are definitely specific studies for AMD. Not exactly the same for cataracts, but again, it's just that colorful, varied diet, lots of antioxidants. Those are vitamins A, C, and E that you can get through supplementation or even through naturally occurring sources in your foods that are really good.
Great. All right. And it looks like Lisa's done some background research before today. So she mentioned there's two types of cataract replacement for persons with astigmatism. One is more costly, but there's implications for ability to see close-up objects, and eyeglasses needed for post-cataract surgery. Could you just cover a little bit about what that
Yeah.
is?
So I didn't talk so much about this in my presentation, but there are different lenses that we can place inside of the eye. So those synthetic lenses that we place inside of the eye, there is one lens that gives you really good vision far away. But after we do that, you will definitely need reading glasses. So if patients are okay wearing reading glasses, that is a good option for them. We do measurements to know what lens to put inside of the eye. And the main things that contribute to those measurements are the curve of the eye and the length of the eye. So if your eye is curved a certain way, you have what we call astigmatism. We correct astigmatism in glasses. So if you have astigmatism in your glasses, that's because your eye has a certain curve to it where it's flat in one area and steep in another area. I think Lisa's referring to certain lenses that can correct for astigmatism. So there are lenses that we can place inside the eye that will correct that astigmatism if that astigmatism is coming from the cornea or the front of the eye. So typically, I think she mentioned some prices, those are not covered by insurance. What is covered by insurance is the lens that will help you see far away and get that cataract out of the way. So there are certain technology lenses that can be used to correct for astigmatism, and then also certain lenses that have technology to allow you to see up close, like a bifocal or multifocal, so that you're less dependent on glasses, so you can see far away and up close a little bit more clearly. And then there are even combination ones that correct for that far away and up close, plus the astigmatism. So there are definitely a lot of different options. And then in terms of cost, she was asking about that. So the standard one that helps you see really well far away, that one is the most commonly covered by insurances. And then the other ones, depending on your needs, may have some fee associated with it for those different technology lenses.
Great, thank you. And she had a bit of a follow-up question asking about research developments when it comes to the cataract surgeries coming up. And
Mhm.
asked would it be good to wait another year or two? I think a good question to this is what's the research doing in the world of cataract surgery? Where are the improvements coming?
Yeah, I mean, the implants, that's really where a lot of the new updates are coming. There are a couple different major lens platforms that we use in the United States. Alcon is a big brand, Johnson and Johnson is another big brand, Bausch and Lomb. And most of them had recent updates within the past couple years to their platforms, but they're constantly trying to find new ways. And the thing that patients really, really want is more independence from glasses. So a lot of them help you see far really well, and then you have to use the glasses for reading. So we're always trying to come up with better ways for you to see far away and up close and intermediate. So I think those are constantly evolving, but I think once it gets to the point where it's impacting your day-to-day activities and moderately bothering you, there's nothing that I think would dramatically change necessarily in the next like year to year and a half. So if you really think you need cataract surgery in that time frame, it's probably just worth it to go for it. But down the road, I know that's constantly something that they're trying to improve to give you this bigger range of function without having to reach for your glasses after cataract surgery.
Thank you. All right, we do have a couple more questions. And folks, if you do have questions, you can type it again in the Q&A box. So you had mentioned about an eye injury or trauma to the eye post-cataract surgery, but can an eye injury increase your risk of cataract development or
Yeah, for sure. So a lot of the patients that I see that I have to do cataract surgery on in their 30s or 40s are patients that have had these traumatic cataracts. So there's a whole group of congenital cataracts. Those are babies, but then usually if you don't have a congenital cataract, you can get by until like your 50s, 60s plus before you develop the age-related kind that needs to come out. But in patients that have trauma to the eyes, these cataracts can develop much earlier. And as I mentioned when I was talking about kind of the post surgery issues with the lens dislocation, these patients sometimes have some abnormal anatomy. So their support system may be a little stretched or a little bit weak because of that injury. So those are always cases that we kind of have to spend some extra time in and just be really careful when we're in the surgery to make sure that we handle things extra delicately because of those disruptions sometimes to the natural anatomy. But that is a big reason why you can develop cataracts earlier than expected, and then also leads to sometimes a little bit more challenges during the surgery because it can impact that support system of the lens.
And do you see any sort of professions that tend to see this sort of trauma, for example, like veterans or combat sports?
I mean, any contact sport can have this, anything that affect, especially can affect the eyes, like anything with sparring,
Mhm.
wrestling, jujitsu, that type of things. We see a lot of boxers actually that have injuries to the eyes, and they won't necessarily remember it off the bat, a specific injury, but they will tell us that they were a boxer for many years. In terms of occupational, welding, glass blowing, I don't know how many of those there are on this call, but anything with like high light or high radiation exposure can also lead to increased cataracts, but definitely it's the trauma kind of to the eyeball and to this area around the eye as well.
Wonderful, thank you. And someone asked if you could share the websites again.
Yes.
Perhaps just pull up your screen.
Yeah. Let me.
And while we're doing that, someone asked, so cataract surgery can help resolve night halos, and that's a yes, correct?
Yes.
Yeah.
Yeah. So night halos are usually two main reasons why, or maybe three main reasons. So one would be the surface of the eye. So if you have dry eyes, that can actually contribute to blur or sort of glare or halos at nighttime. So we want to optimize the surface of your eye by supporting that surface by with lubricating drops or artificial tears. That's one cause. Another cause is uncorrected astigmatism. So we talked a little bit about astigmatism today, but that's related to sort of the curve of the front of your eye, and we could correct that with glasses or contacts or lenses at the time of cataract surgery. And then cataracts, those are the big ones. So as you develop those cataracts over time, glare and halo, especially with oncoming traffic, that is a big symptom that they're getting worse. So when we remove the cataract, that gets rid of that if the cataract is the primary cause.
Thank you. And I see Jewel raised her hand. Jewel, go ahead.
I'm wanting to know how successful the bifocal lens is. Can you pretty reliably see just near and far with a bifocal? I had heard that that may not be perfected yet.
So I think part of that is just kind of going in and counseling about expectations beforehand. So with the standard lens that mainly for distance, 100% of the time that you look up close, you're going to need to reach for reading glasses. With the
Sure.
bifocal or multifocal lenses, you can see far away, you can see up close. But for certain like really small things, and this is what I tell all my patients, you still are going to need to reach for your lens because like you said, we're not there where it's perfect yet, but you will have more independence. So there will be more times where you can see far away and some things up close than if you got the other lens. But for certain really small things, you still will absolutely, you're right, need maybe a low power reading. The way those lenses, most of them work, is there are these concentric rings that focus light at different parts of the retina for different distances, which is why they work for far away and up close. In the beginning, when you're first adapting to those, one of the things about those lenses that sometimes patients have trouble with is they can actually cause a little bit of glare as your brain is adapting to that lens. Usually that glare goes away within a couple weeks to a couple months as your brain kind of gets used to that new lens in its place. But those rings are what allows the lens to give you that different depth of focus.
Let me add this. So if I were to choose the reading or the near lens,
Mhm.
would I get a better experience when reading um, than I would with a bifocal?
So you're talking about targeting your vision so that you see well, the
Yeah.
whole lens focuses up close.
Yes.
Yeah, so I mean that's an option too. That's something called monovision. So usually we'll have at least one eye, usually your dominant eye can see well far away, and then we can have your non-dominant eye where the whole lens is targeted up close, and then when you have both eyes together, you can see at a bigger range, far away and up close. One advantage of that is because there are no concentric rings in those lenses, you don't have that short adaptation period where you have a little bit of halos as your brain adapts to those rings because there are no rings there. Some people love that option, and some people don't like that there's a little bit of a difference between the two eyes. So with each of these, both monovision and certain lenses that are multifocal, there will often be a short period of adaptation where your brain is just getting used to the change because it is going to be a totally different lens inside the eye than what was there before. So just kind of going in with that expectation. But if you're interested in monovision, one thing that your optometrist or ophthalmologist, who's the surgeon, can recommend is a trial with either glasses or contact lenses to kind of give you an idea of what that might be like after surgery.
So if you think I would have a good experience if I get the lens that would just be for reading, and then I would plan to wear glasses for distance. Was that a good option?
I think it really depends on your day-to-day activities. So if you're doing mostly just near activities, that could be a good option. But most people do a lot more activities than they realize that are at distance. And that's why we usually target for distance. So distance is anything essentially that's more than arm's reach away. So this could even mean your TV across the room. This means driving. So we usually aim so that that is clear and you wear glasses for reading. But if your activities are mainly within your arm's reach, then that would make sense to target for near. But like you said, if you get the single vision lens for near, for anything kind of further away than that, you will need some glasses.
Oh, okay, I know I'm taking a long time, but suppose I get one eye with near and one with far. Do people 90% of the time can adapt to that?
Yeah, I mean, people adapt to that at different rates, but once you do that, we usually target your dominant eye for far away and then your non-dominant eye for near again, because most of our activities are far away, but it'll again depend on an individual case by case basis and what your actual individual activities look like on a day-to-day basis.
Tough making this choice. Thank you very much.
Yeah, no problem.
All right, and we have time for just one more question, but I'm going to make it a two-parter.
Mhm.
One's a quick hitter. First off, can cataracts grow back?
So the cataract itself does not ever grow back because we remove that lens. Sometimes there can be a membrane that forms around the lens that we place inside the eye. We call that a secondary cataract. That is easily corrected with a laser in clinic, and that can develop months to years later. And usually patients will have some of the same symptoms that they had when the first cataract developed, but it's not another surgery. It's just a quick laser that we do to clear that up. And it's a thin membrane around the lens that we place inside the eye.
Gotcha. And then finally, and this is one that we see a lot of questions on, how does glaucoma impact cataract surgery?
Yeah, so both of them can impact your vision. Glaucoma, if you've been to any of the educational programs, usually impacts your peripheral vision first. In terms of how it kind of works hand in hand with cataract surgery. So if you are going to have cataract surgery and you have a diagnosis of glaucoma, which is often treated with eye drops, that's the main way that we treat that to lower the pressure. We usually offer to treat the glaucoma at the same time. So if you're getting anesthesia and we're doing surgery, we're inside the eye, we'll often do a short procedure that only adds a couple of minutes that can help to bring down the pressure so that afterwards, not only will you see better because the cataract is gone, but often we can get you off some of your glaucoma drops as well, or at least make you less dependent on them and bring the pressure to a safer range. So many patients have both cataract and glaucoma, and if you're going to eye surgery for cataract surgery, we often try and address both at the same time.
All right, Dr. Chin Loy, thank you. We're at our time. Thank you so much for a wonderful presentation. For those of you who are interested to have other questions that maybe you just think of now or you think of later, you can always shoot us an email and we can get connected with Dr. Chin Loy. Otherwise, this recording will be available later today on our YouTube page, Your Eyes DC. And if you're looking for it and you can't find it, you can always just shoot us an email as well. But Dr. Chin Loy, thank you again. This was great, and I look forward to seeing you next time.
Awesome. Thank you, guys.